Good afternoon. Today we will deal with scan. So first we will see the extension of scan. Okay. So in this diagram, you can see the scan extends just above the forehead or the upper eyelid, and it extends above the tragus of the ear, and posteriorly it extends above superior lingual line, and it is continuous with the opposite side. So this scalp and face is common in the forehead. So this is the extension of scalp. Let's go into the layers. As the name suggests, it is having 5 layers. S for skin, C for subcutaneous connective tissue, A for epicranial aponeurosis, L for loose areolar tissue, and P for pedicranial. We will see each layer in details. So first skin, as you can see, the normal covering of any part of the body, that is skin. The skin here is thick skin. That is the skin, and it contains, the peculiarities is that it contains hair, sebaceous and sweat glands. Adherent, and it is adherent to the aponeurosis by dense superficial fascia. That is why when we move the scalp, you can see it is moving over. You can feel that it is moving over the heart, that is on the body area, that is over the perineum. Next layer is the dense subcutaneous connective tissue. It's just a close network of fibrofatty connective tissue. It contains the blood vessels and nerves of the scalp. Next layer is the gallia aponeurotica or epicranial aponeurosis. The importance of this layer is that it is sensitive to pain. And this layer consists of 2 muscles, that is, anterior you have the occipitofrontalis and posterior you have the temporoparaetalis. So these 2 muscles fibers are present anterior, and the aponeurosis layer forms this aponeurosis layer. What is the actions? Simply the types of movement is factor in the to and fro direction. Next is this loose subaponeurotic tissue, that is layer which is below the aponeurosis layer. This layer, the importance is that it contains emissaries vein. So since the emissary veins are present in this layer, and the important thing is it is fibrous. So when there is an infection in the face or connecting veins, this infection is carried through this layer to the intracranial surface. So this is a dangerous area of the scalp. This peripherally, it is on the periosteum of skull and it covers the, and it is absolutely Switzerland. Next, go into the nerve supply and artery supply. Here you can see the whole scalp is supplied by, the whole scalp is supplied by 13 nerves, of which 3 are motor and the rest is sensory. Okay? And you should know that the motor nerve is supplied by the facial nerve, and sensory is by the branches of the mandibular nerve. Okay? So here you can see just first nerve is supratropical nerve, supraorbital nerve, zygomatical temporal nerve, temporal branch of facial nerve. Okay, so here you can see this is motor. So these nerves are in front of the ear. Okay, so there are 4 nerves. Okay, 5 nerves which are in front of the ear, and another 5 which are behind the ear. Okay, out of which one is motor. Okay. Let's go posteriorly. You have the greater auricular nerve, post auricular branch of facial nerve, then lesser occipital nerve, greater occipital nerve, third occipital. Clear? So these are the nerves. It's a branches of either facial nerve, 2 motor nerves are branches of facial nerve, and the rest of the sensory nerves are branches of mandible. The same area is supplied by the arteries, that is supratropical artery, which is called as supratropical nerve, supraorbital which is following the supraorbital nerve. Then you have superficial temporal artery, which is the branch of external carotid artery, then posterior auricular artery, occipital artery. Continuing with the arterial supply, the arteries are branches of internal carotid and external carotid artery. So this is the anastomosis between the branches of common carotid artery. Next, venous drainage. Mostly it is drained by the facial nerve. You should know how is facial nerve. This is formed by the supratrochlear and supraorbital veins which join to form the facial nerve at the angle of eyes, medial angle of eye. Then they will continue to the retromandibular vein. Then it strains in common facial vein. So here this diagram you can make out this. So here is supratrochlear vein and supraorbital vein join together to form the angular vein. Okay, so that will continue down as the facial vein. Okay, this once the facial vein comes down, here you can see another vein. This is the retromandibular vein. It is formed by the superficial temporal vein and maxillary vein. Superficial temporal maxillary vein join together to form the retromandibular. At the angle of the mouth, it divides into two branches. That is the posterior and the anterior. So the anterior division joins with the facial vein to form the common facial vein. Clear? And this drains into the internal jugular vein. So this is how internal jugular vein is formed. This you should know. This may ask for the rest. Let's some few words about transitory veins. It is vagus. Its function is to increase the venous pressure. Example for transitory vein is parietal transitory vein, mastal transitory vein. In this diagram, can you see these are the layers? Okay, so this is the skin, upper aortic connective tissue. Next, what you see here, this is the upper neurosis. Next, what you see here is the dangerous layer. Okay, let's have upper aortic tissues here. Let's see the MBBS veins opening. Okay, below that you can see the periosteum. Okay, so here you can see the MBBS veins are opening here into the dural venous sinus. So this is dural venous sinus, which is inside the. So any infections on the skin is having a so they carry by the MBBS vein into the blood vein. So that is how the infection can go from say the leading to meningitis and encephalitis, etc. Lymphatic drainage, namely you should first the important lymph nodes you have to mention is superficial parotid or pre-auricular lymph nodes. Then you have post-auricular master lymph nodes. Some important clinical symbols you can see in the case scalp is already mentions the scalp you have the sebaceous and central. So sebaceous, the hair is not kept clean or scalp is not washed. You can see accumulation of sebaceous leading to sebaceous cyst. This one. Okay. Next, scalp. The scalp is easy to purify because it is having rich blood supply. So once it is sutured, the chances for healing it will be easy because of rich blood supply. Next, you can see surgical term. Surgical as of scalp includes the superficial temporal region, superficial temporal line, and zygomatic arch. Okay. This is cephalhematoma. What is cephalhematoma? This connection between the periphery. Localized perinephoma have cephalhematoma. So, how many difference between cephalhematoma and caput subseminum? Okay, cephalhematoma, it is found below the periosteum. Okay, that is pericranial. So, what happens? It will be in the shape of the remote. That is not coming out of the periphery. So, it is localized under the periosteum. So, it will be taking the shape of the pot. Okay, so you can see here. It's taking the shape of the pot. Here also you can see. It is not spreading. Okay. But in the case of caput subseminum, this is due to prolonged labor simply because of the connection of the subcutaneous tissue. Okay. So that is because of obstruction of venous line. So what happens? It causes the suture lens. Yes, so it is all just below the skin. It surface. It is not deeper. This is subcellular zone. So here we can see capillary it is crossing. This is a cincillum. It is crossing cincillum. And capillometer it is not crossing the cincillum because it is not below the MBBS. Next is bracket. As you see in the plane, it is aponeuros's layer. Two muscles are there. These muscles are not adherent to the bones. Instead, they are adherent to the skin. So what happens if there is an edema in the bone will leak into this loose tissue around the eye, forming the black eye. So this is summary. So here you can see this whole as skin subcutaneous connective tissue, epithelial,